Differences between primary and permanent dentition. Hi, Ria, a passionate undergrad, was excited to be posted in the Department of Pediatric Dentistry. From now on, she will not only be able to treat adults but also young children. But a constant thought that troubled her was how can primary and permanent teeth be differentiated? She needed a quick revision, so she gathered a few models. Something she already knew was that primary teeth are also called deciduous teeth as they shed off. This temporary set of dentition is present in the oral cavity from 6 months to 6 years, after which they are replaced by permanent teeth. By the age of 21, after the eruption of the third molars, a complete set of permanent dentition is present in the oral cavity. As she observed the models, she noticed that although the primary and permanent teeth resembled each other, they also had certain morphological and histological differences. The first difference was the number of teeth. Primary teeth were only 20 in number, 10 in each arch, and 5 in each quadrant, while the permanent teeth were 32 in total, 16 in each arch, and 8 in each quadrant. The difference in the number was because of the absence of premolars and a third molar in the primary dentition. Based on this difference, the dental formula is as follows. Next, she observed the difference in the size. All the dimensions in the primary teeth were smaller than the permanent teeth because children have smaller arches. As the arches grow, they accommodate the larger permanent teeth. Next, she looked at the difference in the color. The primary teeth were lighter and had more of a bluish-white appearance, while the permanent teeth were darker, appearing gray or yellow-white. This color difference is because of two factors. First is that the primary teeth have a thinner layer of dentin, while the thicker layer of dentin in permanent teeth makes the tooth look yellowish. The second reason is that since the enamel and dentin of primary teeth are formed in utero, there is no exposure to environmental factors during teeth formation. This enhances the quality of the enamel and dentin in primary teeth. Pop quiz. As Ria began to look at each tooth closely, she noted the morphological differences. She began with the clinically visible structure in the oral cavity, the crown. The crowns of the primary incisors appeared wide. That is, the mesiodistal dimension was greater than cervico-incisal. They looked like Ria's teacup. In comparison, the crowns of permanent incisors were long, like a tall glass, as their cervico-incisal dimension was greater. Another unique feature she observed of permanent incisors is the presence of mamelons. They were absent in primary incisors. Instead, she noticed a physiological attrition of the incisal surface. Did you know? Permanent incisors develop from 3 developmental lobes, and these appear as elevations on the incisal surfaces, called mamelons. She then moved on to the primary canines, which were thin and conical, with a prominent cingulum, while the permanent canines were slightly bulbous and less conical, without a prominent cingulum. All the primary teeth had a marked cervical constriction at the neck of the crowns, whereas the cervical end of permanent teeth were broader. Now she moved further posteriorly to the primary molars. The first molar in primary dentition was smaller in dimension when compared to the second molar, unlike the permanent ones, where the first was larger than the second. Crowns of the primary molars were more bulbous, with flat buccal and lingual, resembling a bell. On the other hand, the permanent teeth were less bulbous with rounded buccal and lingual surfaces. Apart from this, the convergence in the buccal and lingual walls of the molars narrowed down the occlusal table in primary molars in a buccolingual plane, while the permanent molars had a broader occlusal table due to a lack of convergence. This difference is clinically significant because the width of the cavity is limited in the case of occlusal cavity preparation in the primary molar. The relatively flat proximal surfaces of primary molars made a broad contact area with the adjacent teeth. In contrast, the curved proximal surfaces of the permanent teeth had maximum convexity, centered at a point, thereby having contact points to adjacent teeth. Rhea wondered if this was clinically significant. During the class 2 cavity preparation in primary molar, the gingival seat of the proximal box must be placed below the contact area. By doing so, the class 2 restoration falls into a self-cleansing area and prevents accumulation of plaque. Rhea continued with her observation. A unique feature of the primary first molar was the more pronounced cervical ridge on the buccal aspect, a feature absent in permanent molars. This difference is clinically relevant as the pronounced cervical ridge provides natural retention to the stainless steel crowns. Therefore, the buccal and lingual surfaces of primary teeth remain unprepared during crown preparation. In addition to the above differences, Rhea also noticed that the primary molars had many supplemental grooves, unlike the permanent teeth. These grooves act as plaque retentive areas and increase the incidence of dental caries in the primary dentition. Cusps of primary molars were shorter, sharper, and more pointed. These become relatively flat as the teeth undergo physiological attrition during the mixed dentition stage. Now, Rhea observed the roots of both the teeth. First thing she noticed in the roots was the difference in length and thickness. The roots of primary teeth were long and slender, while those of permanent teeth were short and robust. The second thing that was well appreciable was the divergence of roots. The roots of primary teeth were more divergent and flared to accommodate the permanent tooth bud below, while the roots of the permanent teeth were less divergent. The third difference was the roots of the primary molars had a short trunk, placing the furcation area more cervical and close to the pulp chamber. However, the root trunk of the permanent molar was larger, thereby pushing the furcation area further apically. The root surfaces in primary teeth were not smooth and even, and Rhea wondered if this was a pathology. But the answer is no. This was a physiological resorption of the roots, as these teeth shed off. However, if this type of resorption is seen in the roots of permanent teeth, it is considered to be pathological. These were the differences Rhea could see, but there was a lot more that needed to be observed under a microscope. She began to observe from outside inwards. The first visible layer was the enamel. Primary teeth had thinner enamel, with a consistent thickness of about 1 millimeter throughout the crown, whereas the permanent teeth had a thicker layer of enamel that measured about 2 to 3 millimeters, but the thickness varied at different areas. The enamel rods were oriented cervically in primary teeth and gingivally in permanent teeth. Primary teeth had more organic, mineralized enamel. The bands of retzius were less common in primary teeth, thereby imparting a bluish-white color. Another striking feature that Rhea instantly observed was that all primary teeth showed neonatal lines, but only first permanent molars exhibit them. This is because the formation of the primary teeth as well as permanent first molars takes place in utero, resulting in a clear line called the neonatal line, demarcating the enamel formed in utero and after birth. The second layer she observed was the dentin. The dentin in primary teeth was half the thickness of that in the permanent ones. Hence, tooth structure covering the pulp chamber was lesser in primary teeth. But the thickness of dentin at the occlusal fossa of the primary teeth was comparatively thicker. Why is this significant for a dental student? Deep cavities prepared in primary teeth end up in the pulp. Therefore, to allow restoration, the depth of the cavities in primary dentition must not exceed 1.5 millimeters within the dentin. The dentinal tubules in primary teeth were irregularly placed and did not follow the characteristic compactly arranged S tubules as seen in permanent dentition. Does this have clinical importance? Yes, it does. The caries in primary teeth progress faster because of the irregularly placed dentinal tubules. Other features of dentin were the absence of interglobular dentin in primary teeth, a flat dentin enamel junction in primary teeth, and a scalloped junction in permanent teeth. Ria had now reached the third layer of the tooth, the pulp. First, she looked at the size of the pulp chamber of primary teeth, which was larger in relation to the crown and had higher pulp horns, which ran close to the outer surface. She figured that if the pulp chamber was larger, the cellularity and vascularity would be abundant, allowing the primary teeth to have a high potential for repair. This is not so in permanent teeth because of their lower vascularity and cellularity and low potential to repair. Therefore, the reparative dentin below the arrested caries in primary teeth is more extensive. Next, she observed the outline of the pulp. It closely followed the dentino-enamel junction, as if it was guided by the DEJ to take its outer form. This was not so in the permanent teeth. Her focus now was on the root canals. The primary canals were thin, tortuous, and branching, like the roots of a plant. They typically looked ribbon-like while the permanent root canals were well-defined and less branched. This important feature is kept in mind when placing barbed brooches into the primary canals for pulp extirpation. The ribbon shape of the canals may cause breakage of the instrument, which is why brooches are avoided in primary teeth. The tortuous course of canals and ramifications make it difficult to attain complete debridement of the canals. A very distinct feature noted by Ria was the position of the accessory canals. The pulp chamber floor in primary dentition was porous due to the presence of accessory canals in the furcation areas. The permanent teeth accommodate them in the apical region. The clinical significance is that the presence of accessory canals leads to the infection in primary molars draining into the furcal area, forming a furcal abscess. In permanent teeth, this infection drains into the periapical area, forming a periapical abscess. As she observed the apical area of the roots, the apical foramen in primary teeth appeared wider than the permanent, where the foramen is restricted. This causes the infection in primary teeth to be inflammatory and less localized. However, the restricted foramen reduces the blood supply of the permanent teeth and favors healing by calcification of canals as a regressive change. Finally, she spotted the course of nerve fibers in the teeth. The nerve fiber terminated in the odontoblastic region as free nerve endings in primary teeth, while the nerve fibers in the permanent teeth terminated within the odontoblast and beyond reaching the predentin. Did you know? The primary teeth are less sensitive when compared to permanent teeth because they have fewer nerve innervations. During physiological root resorption in primary teeth, the blood vessels in the pulp maintain their normal structure at all stages, although an increase in vascularity and blood flow is observed. The vascular changes in the pulp are accompanied by de-innervation, which decreases sensitivity. As she observed the cementum, she noticed that the primary cementum was thin in primary teeth. The secondary cementum was characteristically absent. This reduces the fitness of the anchorage to the alveolar bone, making it easily extractable. Secondary cementum in permanent teeth is firmly attached to the alveolar bone. Did you know? Because alveolar atrophy is absent in children, gingivitis in a healthy gingiva is rarely seen. After understanding all the listed differences between primary and permanent teeth, Ria was sure she would now be able to clinically implement all that she learned. Pop quiz. Let us end this video with the importance of listing out the difference between primary and permanent teeth. First of all, it is clinically very important to identify the tooth for treatment planning and diagnosis. Second, it helps us to estimate the dental age of the patient. Third, it provides an insight into the eruption status of the child. Finally, it is of great importance in forensic odontology to estimate the age and identity of an individual. We hope you had fun learning with us.